Okay. Our next speaker is Mahir Karakas, who will talk about the role of DDP3 and cardiogenic shock, new medical targets. And we may actually try to pose an audience question, so pay attention.
Thank you. Thanks for having me. So I will talk on the DDP3 targeted biotherapy in cardiogenic shock using protizumab. So what's DDP3? DDP3 is a cytosolic enzyme, dipeptidyl peptidase 3, that translocates to the circulation upon cell death. Sounds familiar, sounds like troponin, but while troponin is not biologically active in the circulation, a dead peptide, this is an active biomolecule which degrades angiotensin II, leads to the dysregulation of the RAS system, results in collapse of cardiovascular function, and thereby results in death very often. It's an established diagnostic and prognostic marker of cardiogenic shock. Maybe you have seen the recent publication of the Lucia group in European Heart Journal, but it's measured in more than 100,000 patients in acute cardiac care and intensive care, more than 40 publications out there in PubMed. And it's always the same story. It's a diagnostic marker, it's a prognostic marker. It indicates shock, circulatory failure, and death. The most recent evidence comes from the ACCOST trial, which was the very first trial to evaluate an antibody in cardiogenic shock trial. If we stratify patients with high and low DDP3, high means above 40 nanograms, which references the 97.5th percentile in the healthy population, you can discriminate survivors from non-survivors in cardiogenic shock. And around half of the population in cardiogenic shock meets this criteria of 40 nanograms. So it's a biomarker, but it's also a biotarget. We know because we injected purified DDP3 from human blood cells into healthy mice and thereby induced cardiac dysfunction within 15 minutes. And if we titrated those up, these mice die, and that didn't happen in the placebo-treated mice within this experiment. So next step was the development of a specific inhibitor, a monoclonal humanized antibody, protizumab. And its preclinical efficacy and safety was demonstrated in 3 independent animal models. And I will, due to the time limitation, I will only highlight the pig model, the most recent model. And here it is a model in which we induce shock, and the animals are sacrificed after the 12 hours, and we have a placebo and a treatment group. And as you can see, the y-axis indicates norepinephrine need. We have a decreasing norepinephrine need over time with protizumab, but an increasing norepinephrine need with placebo. Same with the respiratory function. While protizumab substantially sustains the respiratory function in this pig model, the placebo-treated animals deteriorate and show lower respiratory function. And very interesting, we have a strong pleiotropic effect among those. Interleukin-6 is very interesting. The heart interleukin-6 expression. Look on the left side, the most right bar here. The protizumab-treated animals have a similar interleukin-6 expression in the heart as the sham-treated pigs, while the placebo group has a very high expression of interleukin-6. And this translates in a much lower myocardial necrosis at 12 hours after shock induction. In protizumab-treated animals, the troponin level from the baseline is almost the same, while we have a troponin, high-sensitivity troponin I of almost 6,000 nanograms per liter in the placebo-treated animals. So the next step would be the clinical development, phase 1, but we get some human efficacy data even before phase 1. This is the so-called single-patient treatment program, which is unique to Germany, but very similar to the compassionate use. We can do it before phase 1, but only in life-threatening patients, which already entered process of dying, and 3 patients treated so far in this program. And the good news is we have a de-risking of phase 1 and phase 2. We have no adverse events, we have no side effects, no intolerabilities. Second good news is the mode of action is working. Oh, this is, there was an actualization of the slide set. Are you able to switch to that? Just a second. I think the colleagues are on it. But I can do it also on this way. So what we see is mode of action was also confirmed. We have a very high enzyme activity before administration of protizumab, and this immediately drops upon administration of protizumab because we strongly decreased the enzyme activity. And this translates in a much lower norepinephrine need. We start with norepinephrine of 1.0 to 1.6 micrograms in these 3 patients, and we get down to 0.2, 0.1. So we have a shock reversal in all 3 patients within 72 hours. The follow-up was until shock reversal, but not longer than 72 hours. We have the PF ratio improved in all 3 patients, coming from below 100 to almost 300 in all 3 patients upon administration of protizumab. We have the renal function improved, as evidenced by creatinine levels, which dropped from 3 to 1 milligram. We have lactate levels in these 3 patients coming down from 7 millimole to normal levels. And most interesting, again, very interesting pleiotropic effect, we have a strong anti-inflammatory effect. And that's interleukin-6 measured in the circulation, which upper limit of normal is 4, but it didn't matter if we start at 40, first patient, at 250,000, interleukin-6 of 250,000 nanogram, if a patient 2, or at 1,000, we normalize within several days. So it works, seems to work in this treatment group. So next step was phase 1, initiated 2 weeks ago. First patient treated, everything is fine so far. And in brief, 24 patients, 4 groups, 1 placebo, 3 dose escalating treatment groups of protizumab, and all patients will be followed up for 28 days. The phase 2, Survive CS, is a personalized medicine trial, biomarker guided. Sample size will be adjusted during the trial, 380 patients. Very broad inclusion criteria, which you know from previous trials. We have an enrichment criteria. DPP3 must be elevated, 40 nanograms. Half of the patients will meet this criteria. And these patients will be randomized 1-to-1 either to protizumab, 10 milligrams, the dose we used in the single patient treatment, or placebo. It's a single infusion because we know that the effect lasts at least 1 week. And primary endpoint will be assessed at 30 days, secondary endpoints at 7 and 90 days. And patients incapable of giving an informed consent are allowed in this trial. Primary endpoint is a hierarchical primary endpoint. We will calculate the win ratio. We have ordered the 3 individual endpoints according to importance: death at 30 days, cardiovascular organ support until day 30, and respiratory organ support, invasive mechanical ventilation until day 30. We have exclusion criteria, very common to previous trials. I just want to highlight that resuscitation is limited to 15 minutes, and although we have no safety signals, we will exclude patients with severe pre-existing hepatic disease and pre-existing renal disease. So in summary, we have with DPP3 and protizumab, we have a very strong biomarker, which is also a biotarget. Mode of action it was confirmed in pigs. Looks like it's also confirmed in first human efficacy data. Phase 1 started, and phase 2 will start in November or December of this year. And besides 4 countries in Europe, we will also include around 5 sites in the US. Thank you very much.
Mahir, that was
Sure.
That was fantastic, and thank you for sharing and summarizing the science behind this. We are going to be asking some questions of the audience, not like the old days, because they asked us to, but who in the audience, and Stavros, you're up, who in the audience would have equipoise to enroll in this trial? This was in the US. This is, congratulate our colleagues from Europe. We don't have to have show of hands, but just talking about this.
Eddie, are you asking who would enroll in this trial?
Yeah, in the US. And the reason I ask is just because it's very interesting that we have a real understanding of how limited we are to impact on this phase of shock, the vasodilatory, whatever you want to call it, the unhinging of shock.
So we have Naveen and
Yep.
then Stavros.
Yeah, I'll let Stavros go first. He's standing. I get to say.
So thank you so much, Mahir, for this great talk and the efforts. So actually, I wanted to ask this after Eddie's talk, but it applies here as well. Given the challenges and the lessons we learned from the trials and the studies, and we discussed this earlier, how you implement these now, right? And I like part of what Eddie said about the 2-heat or 3-heat, right? So essentially the question is, are we going to do this in isolation, or are we going to think of how the shock started, which we know it started from the heart. That's why it's called cardiogenic. And maybe if we just isolate this and not combine it with an MCS intervention, then maybe we are asking too much. Essentially the question is, now that the science is not lagging us behind and we have some targets, should we combine the two? And combine the MCS with an approach, a therapeutic approach. Or maybe if you just try this, then you will end up into going back, improving things a little bit, and the shock will keep perpetuating because you're not going to have the restoration of the blood flow, right? So should the approach be combinatorial? That's the question.
Thank you very much. Before I answer, I want to apologize for this slide failure. It's uploaded. You can see the efficacy data from the first 3 human patients afterwards. We are pretty confident, Stavros, that our therapy will be effective in MCS-treated patients, or irrespective of MCS. And maybe our therapy, and that's why we want to allow patients with MCS here. And just of note, the ACOS trial, which I was a PI of that trial, of this multicenter, this was an investigator-initiated trial. In the ACOS trial, which was only performed in Germany, 50% of the patients had MCS, mainly ECMO and Impeller. So half of the patients will have MCS, and MCS causes a lot of DPP3 release. So the erythrocytes, for example, are full of DPP3, which is released into the circulation. So this might work on its own, but it might also be an MCS-enabling therapy. We will see. The trial will recruit up to 680 patients because it has an adaptive sample size design, so we will have some power to answer these questions.
Yeah, one question I had was just around the target population. So based on, you had some early data just as a biomarker, so 2 questions. One is, how are you stratifying based on the companion diagnostic your target population? So is it just a binary readout? Is it a continuous variable, meaning the magnitude of DPP3 is the target? So maybe you can explain how the companion diagnostic fits into the trial design. And then second question is just targeting the heart failure non-MI population. You just heard, the different pathophysiology, the trajectory of that patient. Do you think a drug like this might actually have more benefit in a non-MI population where, they have sympathetic drive, they've been, systemically neurohormonally activated for a much more prolonged period of time, and you might get to earlier stages of shock as opposed to waiting until they're really in extremis?
Thank you. So we want to do it as a
2 large questions. One is companion diagnostic, the other is heart failure shock.
Yes. So companion diagnostic. Companion diagnostic is pretty easy here. We'll only assess it at baseline. We have a point of care, CE certified since many years. The Mayo Clinic is developing a new reference test. We will have a strip test available in a short time. And we will only assess it at baseline because, as I showed, more than 100,000 patients, data from more than 100,000 patients is available and indicates it's enough to measure at baseline. We have some small additional information if we do dynamics of DPP3. So we might identify up to 5% of cardiogenic shock population who worsens over time within the first 12 to 24 hours. But in order to keep it pragmatic and simple, I guess we will focus on baseline DPP3. Regarding etiology of cardiogenic shock, we need substantial cell death for DPP3 release. So this will be a trial, I guess, with 50%, 60% AMI and 30% septic cardiomyopathy and up to 10% worsening heart failure. The DPP3 positivity in heart failure, in acute heart failure, is around 20-25%. So this is not such an DPP3-rich population as AMI-induced cardiogenic shock.
Got it. Thanks.
Excellent presentation. I have a comment. I come from MD Anderson, so I see the biggest challenge is patient selection, and I heard exactly the panel is. This is an acute situation, extremely complex, and the biggest question that I have for you is what the extent of the workup you do to make sure you have the pure patient where you're going to see the result. And that's the biggest issue I have because they're not that pure as we believe. Yeah. We enroll them in the studies, and of course then the outcomes are a little bit overlapping because we have two different pathologies. And in our patient population, when we started being more aggressive and doing invasive workup, we realized a lot of them are Takotsubo's initial phase, which would recover with a great, almost irrespective of what you do on them. A bunch of them have septic component to that. It's never pure. So how can you, what's the extent of the workup you do in your study to enroll the right patients?
Yeah, you know, that's the beauty of this concept. We think it works in all of these subpopulations. With the experience of 100,000 patients from more than 90 studies, registries, but also clinical studies, randomized clinical studies, we see it works in each subpopulation as soon as DPP3 is elevated. So again, we are pretty confident that there is no need to stratify patients for these subpopulations, but at randomization of a very broad, with a very broad definition of cardiogenic shock, seems like we have a good chance.
Thank you very much. We're going to move on.